told, then I would have been more careful. There is one litigation from a very senior doctor up north. The patient had the same issue. The litigation is that you did not tell me that this has to be done. The doctor said this is not a standard of care. She said, if it's not a standard of care, then why did you recorrect me, and why did you get it done after you did the recorrection? Now cornea. Unfortunately for the doctor, the cornea has become 394. You said you burnt 40 microns. Now I'm sure he is going to lose it, because it may not be the standard of care, but it is available in some place to pick up. Now the question for this doctor is to prove that DLI is a junk. It's very difficult to do that. There's not many papers on it accepted. It's not an accepted procedure accepted, but if it's there, then you have to do it. And the unfortunate thing is the doctor has an eye trace. So if you have an eye trace, you're not done it, and you do it after the procedure is done, and you lose it, right? No, it does not. But like I said, LASIK done on people with other issues like PCODs, cataract, all this other stuff has some oxidative role in it, but we don't know.
So whenever we are doing topo-guided lasers, we are dealing with an irregular cornea, and that's why we need to do it. It can be a keratoconic cornea, or it can be a non-keratoconic cornea. If it's a keratoconic cornea, you have various options based on the topographer and the refractive suite you have. It is either corneal wavefront, ocular wavefront, or the topo-guided removal of epithelium in keratoconic eyes. So let's see the difference between let's understand the basics of wavefront imaging. It can be either corneal wavefront or ocular wavefront, and corneal wavefront is measured over the exposed corneal surface area, and it's based on the calculated differences between the measured corneal elevation irregularities and the target sphere. Eyes with high degree of corneal irregularity can be treated on this treatment.
This is what your Contura is doing, or this is what your Topo-Guided treatment on Alcon is doing, or Alcon
Zeiss.
and Zeiss. They're just interested in how irregular the cornea is. This is what a Schwind would do, but they also have this option when it actually takes in the whole account of the eye and not just irregularity. The concept here is that this irregularity of this, for example, if you're looking at a corneal wavefront like a TCAT from Alcon, completely dissociates that there is a lens in the back. The machine software is programmed only to take care of this. It's not worried about other optical system. This looks at the complete eye, but still it's incomplete. The next generation of LASIK, which is going to come to treat normal and irregular, is called InnoVise, or the ray tracing. Ray tracing takes care of the eyeball axial length, anterior chamber depth, and within seconds it makes a program of the whole eye, and then it gives you a laser planning. It happens within seconds. That's the speed in which it does. The entire measurement is taken from Pentacam, called Pentacam Wave. It's the next generation of it, but for this is how it does. But there is a huge amount of difference in how the laser ablation is done. That's because the lens actually negates a lot of this thing here. So when you're doing corneal wavefront, ocular wavefront, it tells you that you don't need to worry. Everything should not be loaded on this. Kindly load a lot on the lens also and give it a try. So that's why when you do a laser versus this, if you have it, if you don't have it, 99% of people doing laser basis on this only, because there are not many good laser the corneal wavefront guided treatments available in the country, except for the pyramidal system from Schwind. If you can go back to the next slide. And this is I'm using one company here for the sake of it, but I use both, but more or less the planning, everything is the same. The interface looks different. And this is an abrometer, which gives you the total. This is the cirrus, and this is not actually an
Corneal,
abrometer.
just corneal.
You can't call it it's just a corneal abrometer, but this is a total one. Then the reason people don't like using the total wavefront is the machines are not there which can help you to capture an irregular cornea. So that is one of the challenges of this. Then once you have the machine captures this wavefront, this is something which is quite unique in Schwind, is that you can actually select aberrations which are the main culprit. The machine itself will select. The one which is in gray is one which the machine assumes that they're not your culprit. It is like your culture plate, where the one bacteria which are non-significant don't grow. The ones which are growing are all thriving on green colored areas. So green color areas are the ones which are significant, are the ones which is going to be treated. When you use, say, technologies from Alcon or Zeiss, this interface does not exist. Machine assumes that the entire cohort is a culprit. So it uses a carpet bombing effect. So why do we need this is, every time we take one of those aberration out, you save 1 or 2 microns of tissue. Every time you save a lot of, you at the end of it, you'll save around 15-20 microns of tissues, which are precious gold when you're actually operating on a keratoconic eyes. So you end up in saving, which you cannot do in any other machine at this point of time. Technically you can do, but the machine is rigid in that software. Then, for example, remember what the picture I showed you. When you do a corneal only, the machine assumes that entire cornea is the culprit. There is nothing called lenses. It's making an ablation of 90 microns, and in the center it's making a 24 microns. But when you bring in a lens to support itself, the ablation suddenly drops to 9 microns. That means the machine was actually burning close to around 15 to 16 microns, which is unnecessarily burden of burning the cornea. So this is a very important factor in understanding the laser correction. When you are having a very thinner corneas, how do you balance it? Then, look. Exactly, because you don't. Sometimes, healthy aberrations when you treat, sometimes may end up in patients having loss of depth of focus. These are keratoconic eye, it's okay, but you do it in a normal, say, contura and other stuff. Sometimes, you need some aberrations to give you depth. And this is a patient with -4, -6 at 40. And this is your planning, this is an OW is ocular wavefront, CW is corneal wavefront, aberration free is normal. CW is nothing is just your contura. People using contura is contura. For people who are using Zeiss, is called Topo-Guided treatment. OW, if you're using a Bauschen LOM, it's called the Zyoptics. Here they call OW, and there is Alcon does not have it yet. But their ray tracing, which is going to come, called InnoVice, is going to be, it's called don't know what's called, smart.
Site map.
Site maps is what they're going to come at. This is what they're going to be.
Sorry, but to use the ocular wavefront, you will also have to have the aberrometer.
Exactly. So if you have, it's like earlier when you're using Alcon, you used to get a topolizer and used to get a Schernig based oculizer. So we used to have both, but the topolizer was great, but the abrometer was pathetic. So what happens was everybody discarded it, even we had it. So now the challenge was not the technology, challenge was the machine which could capture the image. But when you have machines which are slowly coming rare. For example, the Alcon is coming out with the Pentacam. It's called a site map. It's just nothing but a Pentacam, but it uses ray tracing principle. So next generation of machines, you can actually buy it as early. So, but this is already there in it. That's why I wanted to use this, because it names are different. It's like paracetamol, Crocin, Dolo, all the same, exactly the same thing. But many times what happens is people confuse with names.
So my question is, you'll have to first do the aberrometry, or
Exactly.
only then can you use it?
Exactly. See, basically the workflow is you do the abrometer, you do the topography. If you have, I'm giving you an ideal situation. What you have today is different, but you should know that there is a situation like this. What do? You do one, you do the two, then then in a click of a button you can compare both of them. So, for example, and then you can go move forward, please. This is what I said. In a click of a button, you have two screens coming up. One from the corneal, one from the total. And if you just screen this, if I'm doing only corneal, I'm going to burn 28 microns. In the periphery, I'm going to burn 135 microns, which is unrealistic. You cannot burn 135 microns and correct a person. But if I'm doing the ocular wavefront, the lens has compensated for 80% of already thing. So I'm going to just burn 9 microns and 58 microns, which is extremely realistic. So if this is realistic, I can choose between what I want. And there are times when it's opposite also. The lens would burn more because it's accommodating more. So then you can choose. So the real idea, I'm teaching you the real ideal way of doing a laser base. But don't worry about what you have or what you don't have. I mean, but this is the ideal way. Then you'll have to stick to this. No. What you can do is, if your numbers are higher, talk to Alcon. They will come out with you can trade your existing pentacam with their pentacam, which is called sitemap. It will, and then you can connect. Then you'll get both. In fact, you don't need this. This Contura will become complete obsolete because you're going to get a complete different form of laser therapy called ray tracing based. What it does is all that calculation is gone. All that 3Z we did is gone. You are completely going to be under control of what the machine actually corrects for every patient. It takes into account of your corneal thickness, ACD, axial length, and it takes close to 20 parameters. And once you feed in your refraction, it takes around few seconds for it to get ready because it's calculating. It's like making a own plan for that axial length, and it will tell you this is what you need to correct. So entire adjusting, everything is gone. Yes. Yes. You don't pick it, but it gives you, it will be something like this will be something like this. It would already picked up what it has to treat. Everything. To be in front of that, this looks little rudimentary. No. It's already in. We're doing their pre-post marketing thing. So it's there. I think they've added few zeros to the price, but but that's all. There's nothing big, just 2 zeros. So, I mean, what I hear is close to around 85-90 lakhs. But I don't know. But it depends on how the Alcon wants to bring the pricing here. So this is how we do. And the question here is, always people ask is, why should there be so much of difference between an corneal wavefront and a total one when you do? Is because of this factor here. This patient has a 5 diopters of coma and 2 diopters of spherical aberration on the corneal surface, which is what your TCAT or Topo-Guided treatment of Alcon would do. Because it just doesn't understand that there is a lens which has taken off half the coma, 90% of coma is gone, 50% of spherical aberration is gone. So beautifully, just these values gets adjusted to this one which is lower here. Everywhere. I'm just using keratoconic eyes because it beautifully summates all this. In regular one, it will be very small. still, in the irregular cornea, yes. In a decentration, when you, but when you're treating a recorrection, with the patient close to 40, about 35, don't worry about this because the lens is stopped accommodating. He's going to stop accommodating. So only stick to this one. So you have to understand that as you grow older, focus more on only cornea as your main, even though it's burning little more, you choose how much to correct, but use this because here it will not work because the lens is not accommodating anymore. So it works for normal as well as the irregular corneas. Then this is what you get. Your refractive error is not exciting as you see in LASIK, but the quality of vision completely changes because it would have changed a lot of coma out here. Then
Yeah, that's it.
Then you go back to irregular. Go back. No, the other one.
The second one?
Yeah. And you can see that you can choose different types of ablation pattern. All this you can't do with other platforms at this point of time. But when you're using a ray tracing kind of a principle, most of it is taken care by the ray tracing software itself. Ray tracing is a complete different game changer in refractive surgery because it looks at every ray of light coming and coming back and how it analyzes this, unlike a bundle of light which comes. So that means their accuracy increases multiple folds.
So next, I think we have a technique which is known as track.
Yeah, we can just show that. Okay, you can play the video, right?
Yeah, and then we can discuss. So whenever you have corneas of around 425 microns where you cannot do a topo-guided laser surgery with cross-linking, we have another technique device which is known as TREC. So we'll just show a small video which will make it simple.
Any questions or anything to be added? Basically, I'm 100% laser-based cross-linking. We do around 1,000 odd cross-linking procedures a month. Wish I could do a year, and we are 100%. That means I don't just do cross-linking. I stopped just doing cross-linking in 2013-14 when, and Gairek is not here. He analyzed the 12 years of data of around 600 odd patients who finished good amount of follow-ups in those 10-12 years of only laser. I have not had of laser versus cross-linking, laser and cross-linking versus only cross-linking. The ones which we did only cross-linking had more instability as far as progression was concerned compared to laser, which is a completely new data, and which I believed in it and I kept doing it, but we had to have that longest follow-up is 12 years. When cross-linking itself is around 14, 16 years old, 16, 17 years. So what I'm saying is, it's a great procedure which gives you a fantastic quality of vision. The cross-linking has stood the test of time. I think you had to go a little step ahead and come out of the comfort zone and start doing it. And these kind of procedures really helps to use it. And the procedure she's showing is called TREC, which is, if you don't want to do a full conventional laser and the cornea is thin, you don't want to see this laser killing of all that healthy, precious tissues of keratoconich eyes. This is something which is very useful. This got published in JRS. Anybody wants, we can send you the full paper for this. But again, reason no financial incentive. Reason I'm speaking about Schwind is it's a black box. When I say black box, the software is so friendly, you can virtually change what you want. You want to decenter laser by 4 millimeters, you can do it. You can move the laser. And this is the beauty of that, is that it's not that others can't do it. Others can easily do it, but others have locked it completely so that you can't go beyond certain level. So that is why it's so easy to do this procedures in this. But hopefully, if you can't, but at least lasers, you can do it all the machines. You wanted to ask something? This is a small video about this procedure, and it's changed the way we have doing cross-linking now when you don't want to do the laser.
The authors of this video have no financial interest. Corneal collagen cross-linking has been proven to cause stabilization of keratoconus and has got FDA approval in April 2016. But the big question which haunts all of us is, what about the quality of vision and life? If we do a textbook survey of the treatment options, it provides us a variety of options which will help in stabilizing the progression of keratoconus. But the question is there nothing we can do about the visual quality? Topo-Guided photorefractive keratectomy requires a minimal corneal thickness of 450 microns. The procedure had good visual outcomes. However, its limiting factor was the thinnest pachymetry. The Cretan protocol ablated 50 microns of the central cornea and hence works better for central cones. When people in different geographical areas have customized their lifestyle based on topography, why should we treat all keratoconus the same? Isn't it time to apply our clinical skills for customization of treatment? We know the cones have different sizes and shapes. So, our research question was, is there any way we can achieve visual outcomes comparable to Topo-Guided PRK? Is there any way to localize and decenter the zone of ablation? Well, now there is. Introducing TREC. TREC stands for Topography Guided Removal of Epithelium in Keratoconus followed by collagen cross-linking. Planning a topo-guided treatment in the Schwind-Amaris platform. The offset of the cone is measured from the pupillary center from the anterior tangential curvature map, followed by measuring the long and short axis of the cone. The ablation depth is set at a maximum of 20 microns more than the thinnest corneal epithelium thickness, measured by an anterior segment OCT. All this is done on the PTK custom ablation module. Intraoperatively, after identification of the cone, a topo-guided PTK is done over the thinnest pachymetry along with a 20 microns of stromal ablation. Next, the epithelium over the rest of the cornea, up to 8 mm in diameter, is manually scraped followed by accelerated cross-linking. There was a significant improvement in post-operative, uncorrected as well as corrected visual acuity, and the procedure had a good safety profile with reliable results time after time. Other applications are intacs, followed by topo-guided removal of epithelium in keratoconus. We can use it to regularize the cornea post-intacs, keeping in mind the ablation zone does not overlap the epithelium over the ring. This gives the patients much better visual outcomes than the intacs alone. With TREC, therefore, we have better epithelial regularization with additional advantage of
This is
minimizing
one
the
where
stromal
you can, even though you can decenter in Schwinn, this is one, you can keep this one. You can actually use this in your Alcon machines also when you know that the cone is not fully decentered from the center. So in your Alcon also, if you use X and Y decentration, manually can decenter, not too much like this, but you can decenter to the where the center of cone is. So we have done it before I had Alcon, before I had the Schwinn. I done a lot of these cases on Alcon machine. Works wonderfully well when it's more of a central cone. Works a little challenging when it goes more to the periphery. So TREC, basically that in Alcon, if you're doing, you do a PTK mode of, measure the cone, do a PTK mode of say the thickness of this zone cone is 40 microns, use 55 microns, use 10 microns more than the whole epithelial thickness. So what it does is it will take off the epithelium, also shave off around 10 microns of the cone. Because it's so biomechanically weaker, even the 10 microns will push the cone back, and then you freeze the cornea with cross-linking. The challenge always is, people ask, when you do that, will this actually increase my cone's bulge? It does not, because you are creating a laser which is a kind of creating a very controlled scarring on the cornea. A scar is exactly what a cross-linking is doing to your eyes. So when you do a controlled scarring, you end up being more stable. It's a 5th or 6th year now with this machine, and all my patients where I can't do lasers, I do this, and it's giving me at least as close result as I would expect with the full-blown Topo-Guided treatment with 160 to 80 microns burning. So you still can do it with whatever machines. Even Zeiss, you can do it if you have a more central cone. That means if you have a central cone, you don't want the patient to undergo a full-blown laser, then this procedures can be adapted, and trust me, it will give you extremely good quality of vision difference, better contact lens fit, and more referrals to you in your practice, because patients suddenly feel that you're not doing cross-linking only like other places. No MMC. If you do MMC, it creates scarring. It does no. It actually creates more scarring than. It's a different wound healing philosophy here, because there's no keratocytes here. Because there's no keratocytes here, the scarring is very minimal. If you put MMC, it reacts, cross-reacts with the cross-linking the oxygen-free radicals, and you create the challenge. Thin corneas, less than 4. Laser ablation.
So does it apply even in cases where you don't really have a irregular or a decentered cone, but you do have like
Yeah.
significant, so the central cone probably,
Works wonderfully well. That's why you don't need Schwinn. You can do it with your machines.
because sometimes you see that it's more or less a bow tie, but it's keratoconus.
You do a PTK of around 7 millimeter on them. You see how beautiful the results are. In their manual removal does. When I see a bow tie, I don't want to do a laser. I just do a 7 millimeter PTK. It shaves off all the irregular ups and downs, and you see a beautiful result. I think we'll have to stop the session. You have all our emails. They can share with you, and phone numbers. If you need anything, please let us know. This course is only 50 minutes, I was told.
Yeah.
So, thank you. I need to rush to a nest hall. Thank you.
Thank you everyone for coming. And if you have any questions, you can contact us anytime.